Okay. That was a little interesting for a while.
Sorry, guys. I was in a meeting and it went a little over and I didn't realize what time it was. I'm sorry.
It's one of those, I'm sorry, I was in a meeting excuses. No, just kidding. It's fine. Thanks. At least we got it. We got it working. Thanks, Angus. I really appreciate it. Okay. Are you in your meeting still?
Yeah, but it's okay. We'll wrap it up here shortly and I'll try to join.
Hey, can you have you made me a host or whatever?
Yeah, it's coming. One second.
Okay, good. Thanks. So I can get people moved over. Thank you.
Okay.
Software
You are
update.
the host and you have full control.
Yeah, right. Tell that to my wife, right? All right, so here we go then. Let me start moving some folks over. Yep, there we go. Okay. All right. Moving along here. And probably just as I get to the bottom, then more people will show up. Okay. I'm going to probably make this a short day anyways for various reasons. So I'm not missing people here. Here we go.
Hey, Paul, this is Steiner. Are you currently at the church?
Yeah, I am. So, yeah, apparently passed with flying colors, so I'm happy. I was a little insecure about it. So it's been good. These guys are great, by the way. Really good people. You know, Bobby's fantastic. And you got my message. I'm going to see Randy, and I think he's going to pull Jamie in this afternoon. Okay.
Yeah, Jamie said that she was available, so it's good. And I'm sorry that I've had such a lack of opportunity to spend more time with you.
You're such a lagger. I cannot thank you enough. You've been fantastic. So, all right, I'm sorry I'm moving everybody over. David, I don't know if you're able to get over David Obert, so I'm trying to get you over. So I'm trying. And the same thing with Johnette. So I don't know. I'm clicking you over. Will you elect to come over as a panelist? Okay, good. I think. Okay, we'll see. Ah. Okay, good. All right, so it looks like we're in better shape over there. So let me get going with the meeting then. Let me see who is on. What participants do we have here? Okay. Hey, Don, well, I got you on. Anybody? Oh, first of all, anybody have restrictions on time so I can get to you first?
Jim
Okay.
Augustine, I have 30 minutes. Sorry.
Okay, good. I'm going to have you talk a little bit about what you were doing. Um, what's Dusty? Could I read this to the panel? It says, Dr. Pepe, my fire chief decided he misses me. I'm going to drop off just before 1200. Okay, got it. I really don't have anything to say. That's true, right? No, it's great. Good, Dustin, miss you, by the way. So I was thinking about you because I'm out here with a bunch of tactical people, and I was talking about some of the great stuff you do here. Okay, so Jim, tell us a little bit about what you did this past week in the great land of Chicago.
Yeah. I was able to breathe through Canadian wildfire smoke,
Yeah,
which is becoming a continental problem and has become an issue worldwide. You probably know at the World Fire Congress that was held a couple of years ago, they had a discussion about common terminology for wildfires and about the international implications of everything that goes on wildfire wise. Air quality and ability for airplanes to operate and all of that are affected by this. And our fire chiefs are spending some significant effort dealing with it. Much less what will be called wildfires with significant urban implications, which is what California and others are facing. And the real life safety issues are there are circumstances like Maui and others where firefighting is not what's called for because you have no hope of trying to stop a fire that is operating under certain weather conditions. And
yeah.
so everyone's joint effort becomes simply around evacuation. So that's going on. There was a study published today.
Before you go off of that, if you don't mind, Jim, before you go off of that,
Yep.
I did want to bring up the fact that the implications are obviously health wise is that people are sucking in smoke and all that. We're getting more and more of that. So that's number one. And I'm going to ask Michael if he could make a comment about that in a second or two, because they've had their own in Ontario. But the other issue is that it's a sociological issue, is that a lot of the people talk about inflation and the cost of everything, the cost of living has gone up. A lot of that's all pushed up by insurance. And in fact, Stein, you want to tell them about what's happening here? Because there was even fire getting close to your house, right?
Yeah, actually over the last 72 hours, I think it was, we had a fire that got within a few miles of our house and was spreading rapidly. Thankfully, they got it under control. We have another much larger one up north in northwestern Colorado that's starting to be a problem.
Tell them what the implications are for a lot of people that we were actually having dinner with the other night in terms of insurance, house insurance.
Oh yeah, that was pretty interesting because I didn't even understand the extent of the issue. But Paul and I were out to dinner with a couple of people, and both of them have lost their insurance on multiple houses because the insurance companies dumped them because of the potential fire hazard.
Yeah, right. So, and then Dustin, you were making a comment that we should all be listening to something, and tell us about that.
Oh, it's a great book that I heard about on NPR. The guy was on NPR, the author. He was a hotshot, but actually before that he was an anthropologist, an archaeologist, and so it goes into a lot of the politics behind this as well as the science. So for the medical sciencey, politically active nerds among us, all of us, it's just a really good, really quick read, but a great book that most people haven't heard of.
Okay, good. Thanks for letting us know. And again, you don't have anything intelligent to say, as you said in the post. So, so thanks for giving that. No, listen, that's great that you're on top of that. I think they need to know that. Let's bump up to over the last couple of years, you guys have had some extensive issues at Mike up in Ontario, and it's affected, I guess, especially your larger populations that you know of in Montreal and Toronto, but so many other places as well, right?
I mean, as you say, Paul, it's spreading across much of the continent, and there's a noticeable, decrement in visibility and air quality and so on. I'm not anecdotally seeing increased rates of respiratory illness, but there's some good reviews out there that the manifestations of this drop in air quality, causing endothelial dysfunction and contributing to cardiovascular and cerebrovascular events. We may actually not be, we're looking for sort of respiratory stuff, but we may be seeing other illnesses rising
Exactly.
in ways that we don't fully appreciate. And that's what I wonder about.
Hey, John Jew, tell us a little bit, since you're having to deal with this all the time as being the medical director for the Forest Service, firefighters that are, catching wildfires up in the Northwest. What are they sucking in? Is there anything, and is there a particular matter that we'll be sucking in as citizens in our communities if it reaches us? And then what are the things to be of concern with? What are the things we should be smart about and learn about as EMS people to know what's in the air?
Yeah, I actually think, how's my audio, Paul? Can you hear me?
Yes,
Okay.
we can hear you.
Okay. All right. So the answer is yes. If you look at we've had extensive fire experience in the West Coast, especially California, Pacific Northwest. That's number one. That's a yearly occurrence. This is not new for us. The quick answer to your question is that there are multiple particles, but the PM 2.5 particles are the ones that are of hazards. And there are almost 2 micron particles that get by the epithelial cells and get into the alveoli. It causes inflammation response, as Dr. Feldman sort of suggests. We have seen acute changes in cardiorespiratory, asthma, et cetera, COPD, cardiac arrest with our wildland fire. We had a bad episode about 4 or 5 years ago that hit the entire West Coast with air quality ratings greater than 170, 180 here as well. So we're fairly used to that here. So the answer is acute short-term respiratory complaints and a long-term cardiovascular stroke and inflammatory complaints. And it gets into the circulation and causes an inflammation response and almost like a autoantibody inflammation response throughout your whole body. So there is clear evidence of both systemic issues as well as pulmonary cardiovascular issues. We would
Right.
the protection for the population, as everybody can hear from this is not new for everybody, but it's a N95 mask if you don't have HEPA air filtration and air filtration inside your house. I personally have a HEPA filter as well as a indoor air conditioning system since the wildland fire started in my own house.
Yeah. Okay. Got it. Mike, and before I get off with you, one last thing, and I may ask this of others, but for you, John, specifically, we all think about you smell it and you're inhaling it, and and it's irritative, and then the lungs may, as Mike and you are both inferring, maybe just a vehicle to get it into us, right? But it goes throughout the body. But the next question is, okay, the smoke's gone and you're in wildfire area and all that. Is there, as you walk through that stuff, is there also other issues as far as what's residual besides what's hitting on the ground or whatever? It may not be necessarily what you're breathing in. Anything you can say about that, or have you ever heard anything about that?
No, Paul, but I think I want to get back to what Jim Augustine sort of said. What we really don't know is wildland firefighters really don't wearing a mask during wildland firefighting is almost a non sequitur. You can't do that with heavy exertion, and it doesn't really work. So
Yes.
there is heavy exposure to 2.5 and all the other stuff. So I think there's a lot of occupational health disease. We attempted to do a pulmonary ultrasound study. It did not get off the ground, but we're still pursuing that. So there is occupational exposure to our wildland firefighters that is very intense.
Well, as many of us do have double roles, serve as public health officials as well. That's why I want people to know about this and be aware of it, et cetera, because it's going to be, I think, a worse problem in many parts of our planet. Mike, you had your hand up. What up?
Yeah, so Paul, I find it very interesting when we talk about the public health aspect, because there's a broader discussion that gets into politics and environment and medicine. And as medical experts and somewhat public health experts, I think it's not inappropriate for us to get involved in the discussions of the environmental change, climate change. Like, this is potentially part of a tipping point in climate change where where our forests are being impacted, where more CO2 and carbon is getting released, and as you have environmental degradation, we can speak out against that. And then there are micro things that we can take. For example, we're switching over in our emergency departments to prescribing the powdered terbutaline instead of albuterol, because the delivery agent is a greenhouse gas. And there are ambulance manufacturers that are experimenting with electric vehicle ambulances because of the short distances that many urban ambulances travel. And so I think we do also have a role to play in saying, what's the environmental impact of our activities?
Hang on for 1 second. Hey, David, I think maybe David Miramonte's mic might be open. Maybe not. We're hearing someone talking over you, so I wanted to interrupt it. So, but go ahead, go back, Mike. What you're saying?
Sorry, I just sort of completed my comments. It may be, as medical and public health leaders, that we can also reflect and work with our EMS agencies on what's the environmental impact on their activities, because this is part of it's going to take a broad-based, multi-pronged effort. It's not just putting out fires or making our communities resistant to fire or using N95 masks. It's what's the underlying societal and climatic implications of what's going on here, and what impact do we as EMS physicians have? Yeah.
Okay. Well, exactly right. That's why I'm trying to sort of alert everybody to be thinking about this. And there's a thing, and I think that especially Nick, tell them about you guys had to run that Lollapalooza last weekend. I've always thought of New Delhi being the worst air quality in the planet because they'd have 800, the AQI being 800 or something like that. What was it like this past week in Chicago, as we heard from Jim?
We got pretty lucky with temperatures in the mid 70s. The week prior, we were more worried about that because temperatures were in the high 90s. About 550 patient evaluations on site, only about 49 transports. Contrast that to 2013 before we had on-scene medical care. We're talking 600 transports of the system. So overall, well-coordinated events. Really no increased respiratory complaints like we thought, considering the air quality with the Canadian wildfires. We're making it one of the worst air qualities in the world, but overall, good, safe event, good music, and nice time in Chicago.
Yeah. Okay. All right. I don't know if there's any other comments to make about that. Ben, since you're a public health official in Milwaukee and you guys are nearby Chicago, I'm sure you were hit. Anything to report out of there?
Yeah, we've been having really poor air quality levels today included as I look out the window. We have noticed, now we haven't ran any statistics on it, but when we look at our trends in respiratory events, it seems like they're higher during these days. We have to, that's kind of a visual look as opposed to any stats. So we'll be looking into that a little bit deeper. Of course, there's inequities and kind of who's affected by all this, all the guidance of, stay inside, use your air conditioning, these sort of things don't apply as well to, a huge portion of our community, and I'm sure many of yours that don't have air conditioning or don't have stable housing. Or have respiratory disease. So that's something we're keeping an eye on.
All right, got it. All right, maybe we've gone a little bit too far to that. I want to catch a couple of people before they leave. Joe, you have to get off. Joe Holly, anything to report from your end?
Hi, Paul. I do have to jump off just momentarily, but nothing new from my end of the world.
Yeah, it's good. Well, there is something new regarding your end of the world. I talked to Richard Walker at great length. What a great guy, and he's very supportive of you. So even when it sounds like even if there's issues with the hospital, he's always on your side. So sounds like a good guy. So we're going to work something out there. Okay.
Excellent. I'll look forward to having you in the area.
Yeah, tell him I said hi. Okay, so take care. And then
Thanks.
I'm getting in about an hour. I'm getting certified in CIT, so that's another reason to come by and learn how it all started there in your realm. Okay. All right. So let's see. Anybody else that had to get off? I can't remember that want to pipe in before we switch subjects.
Jim Augustine, the other event of the day is a study published on firefighter cancer with expected results.
Oh, yeah.
Increased occupational incidence of a variety of cancers. Thanks, Paul.
Yeah. I saw that just now in JAMA, right? And so I was going to bring that up to you guys to do a repeat performance. But maybe if you want to talk to us a little bit about that, that would be good. And for you, just this little note for you again, right there you go, Jim. Jim, yeah, that's right. So, hey, Nick, tell Jim next time he comes to Chicago where you're going to take him, right? So, all righty.
Definitely going to Valari.
That was what I told you about, Jim. Okay, so let's move on. So let's go ahead and talk. Last week we had this great presentation by Nick Burgraff and about this 8-year grandfather's heroin, right? When it comes to ODs and the incredibly interesting physiological effects that fentanyl has that we don't think about that could be causing some of the, respiratory compromise. We always think it's something hitting the brainstem and making you not breathe so well, so you get hypoxemic and you get whatever. So it's a direct effect from that. But fentanyl has in these indirect routes, as we heard last week, that go through things like 3, 4, 5, keeping the diaphragm here wooden, and in this particular case, in other things. But there's also the largest nerve we have out there is the vagus nerve. So CNX, as we say, is basically something that is also affected by in his work that he's done by fentanyl. And so seeing that gives us some additional insights and also begs more questions. And I think you'll really like his presentation again, like we did last week. All right. So going forward, hit it. Okay. Thanks a lot, Nick. Welcome back. And everybody remembers Nick from being from the University of Wisconsin. He's in a department that does basically basic science work, particularly in the land of animal research, et cetera, and has just been a leading person in doing some of this just great work. So thank you so much for being here and sharing this with us from your Department of Comparative Biosciences at the School of Veterinary Medicine at UW. All right. Thanks a lot.
Yeah, thanks, Paul. Yeah, so we studied central respiratory rhythm generation for a long time, and saw how fentanyl and different opioids were able to shut that down in different ways to counteract that. But now we're getting into more of the stuff that we're working on currently, which is some of the more peripheral effects of the opioids. Because what we were finding is that we could, we had 100 different ways to reverse central respiratory rhythm suppression. But it really didn't matter if the airways were closed off and the chest wall was rigid. So that's some of the work that we've been working on lately. So not your grandpa's heroin, as Paul said. So
And the implication, real quickly to interrupt you, is that don't expect the Narcan to work on that kind of thing. Right?
yeah. So a lot of these effects that we were finding are somewhat Narcan resistant, which is making it even worse. So everyone here is aware opioids are powerful analgesics, but they do have side effects. And so many of those side effects are what we're trying to understand mechanistically so we can try to overcome them, whether it means adding adjunctive therapies with the either with the opioid or with Narcan itself. So you might not have to use as much, prevent some of that wild overshoot, et cetera. So opioids, again, result in both central and peripheral effects. You shut down respiratory rhythm generation, so your breathing frequency drops. But what we were finding also is that you're getting a bit of airway compromise that actually can be quite severe, as well as rigidity of many of the respiratory muscles, so the diaphragm, abdominal, intercostals, things like that. And so the airway dysfunction, along with the wooden chest syndrome, or the rigidity of the respiratory musculature, makes it difficult to bag mask ventilate the patients as well. So one of the other things that we're also going to cover here that you'll notice a bit of a theme is that not all opioids are created equal. And so while morphine and fentanyl are both very powerful analgesics, a lot of the negative effects that we're seeing on these peripheral factors happen more with the synthetic lipophilic opioids such as fentanyl. So we talked a bit about last week, talking about some of the effects on the diaphragm activity or the respiratory musculature becoming stiff. What we're going to talk about today a little bit for our little science break here is the effects on the airways. And so one of the things that happens when you give high dose boluses of opioids, specifically fentanyl, is that you start to get a bit of airway collapse. And so if you take a look here, blue is just an airflow trace, so inspiration, expiration. And the gray is a diaphragm EMG. And so normally every time that the diaphragm contracts, airflow goes into the airways almost instantaneously. So it's a pretty beautiful system. Problem is when you give fentanyl, you start to get this period here where the diaphragm is contracting long before any airflow actually goes into the airways. And so you're having a respiratory effort on top of closed off airways. That doesn't happen. At least we haven't seen it as often with morphine. You get the same amount of respiratory suppression if you scale the dosages of opiates, but that airway collapse or dysfunction seems to be specific to that of fentanyl. So you can just quantify latency between when the diaphragm turns on and when you actually get airflow, and that goes up with fentanyl and not morphine. And so, when we were starting to figure out what in the world was going on, we just started by sticking a laryngoscope down and seeing what was happening. Started with the upper airways. So it's a mouse, they breathe really fast. You can see the larynx opening and closing every time it takes a breath. Once you give fentanyl, it initially slows, you get a little bit of constriction there. And then as you'll see, you do get collapsing of the upper airways here, build suspense, cool little movie there, it shuts down. So that's not good if you're trying to breathe, right? And then later on in the fentanyl, so this initial portion here happens within seconds to minutes after giving the fentanyl, and it usually tends to also go away. But what we're more focused in on the sustained effects that last much longer, where you can see instead of properly opening and closing of the larynx and getting smooth airflow, it's just sort of kind of snapping open with enough negative pressure to actually pull it open. So that's not very efficient for breathing. For anyone that's curious, just a little comparative aspect here. If you do this in rodents, most of the transient obstructions happen during inspiration. So it's an inspiratory obstruction, whereas in goats, if you do it in goats, it's expiratory. Looks the exact same. It's just an inspiratory in rodents and expiratory in goats. So there you go. There's your little fun fact. Yeah. So we wanted to see whether or not the lower airways had anything to do with this, because once we, got past the upper airways, a lot of that's already known that some high-dose opioids can cause collapse of the upper airways. But we wanted to move down into the lower airways, some more of those sustained effects that happen. And so what we did was we gave fentanyl along with salbutamol IP And what you can do is you can give the same amount of respiratory suppression, but you don't get any of those airway collapses to occur. So it does seem to be that there's a lower airway or smooth muscle constriction component going on with some of those transient obstructions that we see. You can get the same thing by co-administering epinephrine. It's not as clean, but you do get that effect. So, giving salbutamol with the fentanyl or salbutamol with the Narcan to lower the dose of Narcan does seem to be a viable way to get past some of those transient airway disruptions that do happen. The only thing you have to take into consideration is, you do have cardiovascular effects happening from the opioids as well. And salbutamol and epinephrine don't always, even though you're opening up the airways, you can make deoxygenation worse if you're not careful with the dosing. So,
Quick question before you
yeah,
move on.
sure.
So because of the stimulation that's going down there, such as like what we might see, I'm just making this stretch, and it may be different in the animal model versus the human. Do you also see increase in, say, mucus production, as well, or is it just simply a smooth muscle that you've seen so far?
No, as we'll see in a couple other slides, there's airway disruption. That's the best that we can say. Whether or not
Okay.
it's completely constriction or if it's mucus, we don't know yet because, when we give atropine, as you'll see, it reverses all of it. And that's not necessarily specific for mucus
Right.
or for constriction. So, yeah.
Yeah, okay, good. I just thought at this point in time it was a good question to ask, but again, with the clear limitation that this is a different role and you can't see all that stuff so well. But good.
Yeah. You must have been a reviewer on our paper. No.
No, I took some classes back in the 70s, right?
Yeah, that was our review. What about the mucus? So then we gave it atropine.
Yeah, okay.
All right, so lower airways. We do a lot of neural control of physiological functions, and so we're looking at the central control of the lower airways, and so patency of the lower airways, whether it be through constriction or through mucus production, is maintained by sort of a parasympathetic sympathetic balance. So you have your parasympathetic output from the brainstem down to the smooth muscle airways, mainly coming from dorsal motor nucleus of the vagus and the nucleus ambiguous up here. When those are activated, it causes closing of the lower airways, whereas you have your sympathetic trunk that causes, with stimulation, a dilation of the lower airways, right? And so we asked the question, does fentanyl then enhance the vagal nerve outflow to actively cause a central airway constriction? And that's what we started to study. And so we went in, looked at the vagus nerve. Turns out that the recording from vagal nerve activity is not as straightforward as it seems, even though it's a big nerve. It's very, very prone to movement artifact or just generalized conductance in the area. So be careful anytime that you're looking at papers that are looking at vagal nerve recordings. They have to be validated with some sort of secondary measure like a lidocaine injection or something else.
And also people think of the vagus as a nerve, right? Can you explain to them a little bit what's actually in that nerve?
Yeah, in the nerve is axon bundles, right? And so you have afferent, you have efferent axon bundles that are going through there. And so a lot of times you'll see on vagal nerve recordings, it'll look a lot like a diaphragm EMG. And a lot of that comes back to there is a respiratory modulation of the nerve, but you do have to be careful in the sense that they are axons. And so if you're not seeing action potentials or clean action potentials, that you're not looking at necessarily the nerve activity, you're just seeing movement artifact that is hard to isolate with the nerve. So anyways, so just something to be aware of, that the vagal literature is a bit flooded with some actual non-vagal recordings put forth as the vagal nerve. So just something to be aware of. So we created custom shielded silver chloride hook electrodes so we could shield off any external noise. We injected lidocaine to show the action potentials from the movement artifact. And there you go. You get your clean action potentials. We can go through and we can sort them so that way we can make sure that we look at each individual axon contribution by itself. So you're not just looking at maybe one loud neuron that's confounding all the factors. And we can look at
Nick, make sure I understand
Sure.
what I'm looking at here. So let's take that thing where it says the millivolts over time. What is going on here? Tell me what the different colors are and why is the dip there and why does it come up again? Tell me.
Yeah. So each of these is an action potential. So this is so you're looking at essentially the electrical activity flowing across a sensor. And so as an action potential comes through, you get a rise and a dip and then a recovery. And so what you can do is that you can take each of these action potentials and you can sort them, because each axon or each neuron has essentially a action potential shape. They're kind of like snowflakes, and you can take them and you can sort them, and you can say all of these spikes in this recording came from this nerve or this axon, whereas all of these came from a different one.
Point is, you're showing your homework and you're looking at all this stuff well. Okay, good. Thank you.
Yeah, we're just doing our due, because sometimes you can get one loud axon and it'll make the recording look like it went up 500%, when in reality it was only one neuron that went up and the rest didn't change. So that's just our due diligence here.
Right.
So you can go through, then you can take a look at vagal nerve activity, single axon activity within the vagus nerve. You can look at all of them and how fentanyl affects them. And so normally you do get a bit of spontaneous activity with the bigger breaths, like you would expect from a Herring-Breuer type reflex. But when you give fentanyl, then you get a large amount of vagal activity, either during the breath or also within the breath during the expiratory period as well. So you can see here, just on a raster plot, how much nerve activity is going on during the breathing phase. So it's a lot more than it was during control. And so here's just a little fun video. Here's your vagus nerve spontaneously firing under normal conditions. You give fentanyl, and here's your vagus nerve with fentanyl. So this is here's your brain normally, and here's your brain on drugs. So it definitely turns it off and certainly doesn't turn it off, or it certainly turns it on and doesn't turn it off like you would expect. So then we have to ask the question, does this vagal nerve activity have anything to do in relation to the obstructions? And so you can take a look at how the nerve activity correlates with the incidence of obstructions. And so you get a pretty positive correlation there. And so you can see out of all of the single units that were tested, the majority of them here in red were positively correlated with the incidence of obstructions. And you did have a few that were inhibited as well. Then the question is, the vagus nerve is a big nerve. It's got afferent and it's got efferent information flowing through it. Are we just getting an increase in afferent activity saying, hey, there's something going on with the airways? Or is it the efferent that's signaling to cause the airway disruptions? So you can take the nerve, you can split it, you can record separately from the afferent and the efferent branches. In the efferent side, when you record, you give fentanyl, you get a pretty large increase in the nerve activity, similar to the whole nerve, whereas in the afferent stump, really doesn't do much. For the most part, doesn't really care about the fentanyl as much. So, all right, we go one step further, then we go into the brain. Like I said, there's two major motor nuclei that control the vagus output, dorsal motor nucleus of the vagus up here and the nucleus ambiguus down here. We have a postdoc in the lab that's a sharpshooter with high density electrode silicone array probes that allows us to record from a couple hundred neurons at the same time in the brain. So we can stick those in the brain. We can give fentanyl. We can see the airway resistance, just a proxy measurement for airway resistance here. So as this goes down, resistance goes up. We can take a look at how the vagal motor neurons themselves, the efferent motor neurons, respond. So we can use optogenetics to tag them to say that they are actually projecting down to the airways. And then we can give fentanyl. And again, when you give the fentanyl, these vagal motor neurons start to dance quite excitedly. So when we're looking at an intact network, we have excitation of these vagal motor neurons turning on the vagus nerve, which presumably causes some of these airway disruptions. But what about the neurons themselves? Is the opioid actually attacking these neurons themselves, causing hyperexcitation like we saw with the phrenic, or is it something else? So we can go in, we can patch clamps to record single neuron activity from those vagal motor nuclei. And in isolation, they actually shut down with fentanyl. So the neurons by themselves in isolation are actually inhibited by fentanyl in an in vitro system. But when you put them in vivo in a whole intact network, they turn on quite profoundly with the fentanyl. And so what this tells us is that there's a disinhibition into vagal motor nuclei from the fentanyl that causes activation following the administration. So basically, you have these vagal motor neurons normally when they're completely isolated from any other input, they shut off with the fentanyl. But when they're intact, there's likely an inhibitory population of neurons projecting onto them that express the opiate receptor. The fentanyl binds to the opiate receptor, disinhibits them, and causes them to become active. So that's that. So then if the vagus nerve then is the excess vagal activity is causing the airway disruptions to occur, then if we remove the activity or prevent its output, we should be able to prevent or reverse the incidence of these airway disruptions. So we first took a sledgehammer approach. We used a vagotomy, just cut the vagus nerve on each side. That's an easy way to prevent any vagal input into the lower airways. When you do that, you prevent any incidents of those airway disruptions from happening. And then you can also do the same thing with the vagus nerve intact, but give the animals atropine at the same time that you give fentanyl. And if you're co-administering atropine, you also don't get any of those obstructions to occur. So it does seem to be that the vagus nerve is playing a part. So fentanyl seems to increase the vagal nerve firing, seems to be causing these obstructive events. Lastly, again, just to drive home, almost kicking a horse at this point, if it is a central mediated activation of the vagus nerve, then if we give intercisternal naloxone to keep that naloxone central and to prevent any naloxone binding peripherally, we should be able to reverse the obstructions, and we do. So you give fentanyl, you get those obstructive events to happen, you administer intercisternally naloxone, and you can completely reverse the incidence of those airway disruptions. So that's the part 2 with the vagus nerve. With the fentanyl.
That's great. So essentially, what we're saying is that, I mean, is that there is a large neurogenic component here, both at the and we're just identifying the beginnings with the phrenic and vagus nerves, right? They have such a so you're having a thing where your diaphragms, as I mentioned last time, does 80% of your tidal volume and you're opening up dependent lung zones. So now they're locked out. So you may not get blood flow through the lungs, and you're not oxygenating. You're getting VQ mismatches or outright shunt. And then you compound that with the airway closures and then all that may make it even tougher, even if you intubated the patient, to give a large enough breath to go. So it's an issue. And then, of course, as a result, the naloxone doesn't work in all these cases, and that's why we've always talked about waterboarding with naloxone, and we thought it had to do with the additives that were given into those circumstances. Tell me though, I want to understand the intercistern thing, why it worked there. Okay, why is the Narcan and naloxone working that? I'm trying to understand that physiology.
Yeah, so we're thinking that in the vagus effect, so in the wooden chest syndrome thing that we were talking about last week, a lot of that seemed to be coming from that off-target binding of the fentanyl onto subclass of potassium channels. In this case, we don't think that that's the same mechanism happening in this area, and so it seems to be that the vagus nerve activity increase from the fentanyl does seem to be reversed by naloxone, especially if the naloxone is acting centrally. So if you put it systemic, it's going to go centrally as well because it can cross the blood-brain barrier. But what we wanted to do is just say, hey, if any of these airway disruptions are happening because of just the opioid binding directly to the smooth muscle of the airways, then if we give an intercisternal injection of naloxone, it shouldn't really have much of an effect because it'll stay central. But if it is happening from the central effect, then it should be able to reverse it. So that's we did the intercisternal naloxone just as a way to show that it is a central effect. But yeah, because of the fact that naloxone does reverse the vagal nerve activity increase, it does seem to be that whatever is causing it in the brain does seem to be an opioid receptor dependent mechanism versus like off-target potassium channel.
Right. Okay, this is great. And so let's just now back off and say, okay, these are antibodies. This is preliminary information. It's for us hypothesis generating. But down the line, what's the implications based on what you're finding that we would be doing clinically? Should we give something else besides the naloxone? I don't think we'd want to give epi to everybody, for example, right?
No, but I think, if there is some sort of adjunctive and we do have all the stuff on naloxone going on as well. Right now, we're studying a lot of that big overshoot that you give from naloxone because obviously when you give naloxone, they come alive pretty fast, but it actually overshoots and causes some problems, like you said, the waterboarding from naloxone. And so if there's a way to add, let's say, adjunctive salbutamol with naloxone with a lower dose of naloxone, right? Because you don't need as much of naloxone as you give to reverse the respiratory rhythm generation effects all the time. But if you can open up the airways, dilate the airways, and give less naloxone, you can sort of, gently push them back into the life of the living rather than just giving a sledgehammer effect of reversing it. Or like we're finding with atropine too. Again, the problem with salbutamol and atropine that still has to be fleshed out a bit is the fact that you're not just getting the effects on the airways, right? You're also getting the cardiovascular effects that have to be accounted for as well. But that's what we're working on right now. Yeah.
Great. So Ken Sheppy, should I ask him if ketamine works there?
Yeah, I
Well,
guess
well, you know, the whole time I was thinking, let's just use ketamine.
yeah. I mean, I think the
Where's
biggest.
Chris Colwell? He'd want to use droperidol, right? No, but Ken is one of the smartest guys in the room, by the way. You haven't met him yet, Nick, but he
No.
understands biochemistry really well. This is right
Sure.
up your alley, right? Ken, you want to make a comment, your reaction to this?
Well, it's fascinating data. I really appreciate you presenting it, and it's really cool how you did the whole experiment on it. You know, I personally stopped using fentanyl for this type of stuff a long time ago because I do think ketamine's a fantastic option. But many people still use fentanyl. So have this kind of data and how you can reverse it, that's really invaluable stuff for all of us. I appreciate it.
Yeah. So
Yeah,
good.
thanks.
And good to see you, Mr.
thanks.
Deputy Secretary. Hey, did you guys have a good meeting yesterday with Don Jenkins, et cetera, in the group?
Phenomenal. Yeah, we're all moving. We're for the group. We put in. It's public now, so I can say it. You know, Texas was the first with Don and a bunch of folks from Texas to put in to get $10 million from the legislature to get pre-hospital whole blood out in the field. So following early, because you know we've been doing blood in Palm Beach County Fire Rescue for years, and so in Broward and a couple other places, but it's not nearly as widespread as it should be. So I put in for a budget proposal for our legislature for 15 million, because you know, Florida, you know, I play for Team Florida. I don't want to be second to anybody. So they got 10. I'm asking for 15.
Okay, great.
And it was really valuable. So, you know, they learning from their experience has been really great. So for those of you looking to do it in your own state, those guys from Texas are fantastic. They have a lot of experience. We're trying to avoid some of the pitfalls they had. And if you're going to do a legislative thing, I'll just say right now, don't say whole blood, say blood and blood products, so that it gives you, it makes it broader for you, what you can use the money for. And we're still moving down that. And right now, it looks like we have a lot of tailwind on this. This may actually go for it, but it's a long way to go. And we're in a DOGE sort of set of mind, so it's hard to get extra money. But this is truly a life-saving program. So hopefully we can get it passed.
Especially if we move forward with Salsa Verde, you know.
Yeah.
As John and I always joke about. Anyways, I'm sorry about the digression there for a second. I just, Ken's got a tight schedule all the time, so I wanted to lean over and hear how his meeting went yesterday. But anybody have any questions or any other comments for Nick on this whole issue about what happens with fentanyl? Yeah. So if not, I just want to thank you, Nick.
I have a quick question. So I think Ken addressed the fact of us maybe leaning away from fentanyl, which many of us have for certain situations. This though is appropriate for the patient who has overdosed on fentanyl. And are you then suggesting, and I know, and maybe you can make a comment on this. I know that you had prepared on loading a protocol with the Seattle folks on using albuterol in their treatment of overdoses. Can you comment on that specifically, if that's what the next step should be from a clinical perspective?
Yeah, I mean, so the idea of our research is try to provide for some sort of clinical insight, right? We're trying to translate the research as best we can. And we had, when I was in Seattle, so I was at Seattle Children's Hospital before I was here at University of Wisconsin. And we were starting to put together a trial to see whether or not we were able to co-administer either atropine or specifically salbutamol with the paper that we published with that, with Narcan, so you can lower the dose of Narcan and also give some sort of adjunctive with the salbutamol. As we were starting to put that together, that's when I had gotten my job here, and so we kind of shelved that at the process. But we do have the outline of the the trial that we were putting together. If anyone is interested, in putting together some sort of preclinical type of trial, I'm more than interested and more than willing to get that up and running again. I had to get the lab up here started, but it's definitely something that's pretty much ready to go.
What outcome measures were you looking at for that particular trial?
Yeah, I'd have to pull up, but we were mainly looking at, I mean, number one is going to be survivability, right? What is the what is the death rate versus of not? But the other one was going to be oxygenation, and to the best we can, some sort of measurement of respiration we had in there as well. But we were trying to keep it relatively simple to see whether or not it works. We needed to flesh out more of the cardiovascular things, because the biggest thing that we were concerned about is that when you start to suddenly open up the airways, you're starting to create a VQ mismatch, right? If you don't have the blood flowing to those dependent airways. So that was one of the things that we had to flesh out still that we haven't done yet. And a lot of that was from the fact that I know a lot of the things that we can do in the lab to measure cardiovascular function, but when you move it out to an in-field type of thing, you guys are more of the experts than I would ever be.
Yeah. And a lot of us, like to think that we just don't go right to naloxone. We're always having this breathing first and then think about naloxone, because sometimes we don't even want to wake them up, because if they're at least somewhat with us and not totally compromised cardiovascularly. But then there's the whole issue about with John Jew, you've been doing the work and talking about, tell us a little bit, John, about giving naloxone in cardiac arrest patients that you've been doing it and why you're doing it.
Yeah, I think
By the way,
presented.
one thing, but before we go any further, Nick, do send me if you don't mind, the protocol that you had. I'll take a look at it. If I have interest in people, we'll get you back to you. We're not going to steal it, of course, but it's a matter of, just to have the information and see what it is. And maybe we could give you some feedback about how to alter it as well. Okay?
Sure.
Okay, good. I'm sorry. Go ahead, John. Tell us a little.
Yeah. Thanks, Paul. We in the Portland area have had I would say, an epidemic of illicit fentanyl, as everybody here knows, on the West Coast. And we've actually the real question is, does naloxone have any effect in out-of-hospital cardiac arrest? And there's been basically no conclusive literature or actually signals to suggest naloxone has any outside effects. So we started administering naloxone for our out-of-hospital cardiac arrest, and these are adjudicated cardiac arrests. And basically, we found that for patients in cardiac arrest, naloxone in a retrospective study, our study, had a better outcome in both RRSC as well as discharge from the hospital. When we looked at the subset of our patients, almost all the patients had PEA, and we believe they were, I use the term false PEA, where there was rhythm and blood pressure. We just couldn't find it here as well. So we've actually changed our guidance from basically medication indeterminate to possibly effective for out-of-hospital cardiac arrest in our setting here as well. By the way, Nick, I put in the chat, we've had 2 wooden chest syndromes over the last 2 or 3 years, and one we basically bagged through, and one we had to paralyze and intubate because we couldn't do any resuscitation on that patient. Both of them survived, by the way. So that's our anecdotal case reports.
So one challenge to that, you said when you paralyze them, theoretically that works on skeletal muscle, but not the smooth muscle that's being affected here. From my point of view, can someone correct me physiologically and see if there may be a rationale for that?
Yeah, that's the paralytic's going to be skeletal muscle, right? So that's one of the things that we in the grant we had to sort of decipher between was when we were studying upper airway and lower airway. One of the things that we were having issues with is that when we wanted to study some of the differential effects between the airways, we had to paralyze the animal just for the sake of the preparation, but that got rid of some of the effects that we were looking at. So yeah, the paralytic is definitely going to work for things like the diaphragm rigidity, the intercostal abdominal rigidity, but for the effects of the vagus on the smooth muscle or mucus production or cardiovascular effects, theoretically it shouldn't be affecting it. But that's just
no. Keep your mind open.
We never know. But I was going to say, Jonathan, just for the sake of the naloxone, which you might find interesting, I'll share it really fast here, and then I promise I'm done. We've been doing our studies right now on naloxone itself. And so here is if you take a probe that's measuring a couple hundred neurons at the same time. When you give naloxone, we expect everything to just go back to where it was in control. But when you give naloxone, you're activating different subsets of neurons that were never active with the fentanyl. So you're sort of, what we're saying is naloxone doesn't necessarily bring you back to where you were. It puts you in a different state where you're livable. So if you project the neural network activity here, green is control, red is fentanyl. You're essentially just looking at how the neural network evolves over time. Blue is naloxone. So when you give naloxone, instead of going back to where it was in control, you're actually just shoving the brain into a completely different state that is more livable, but nowhere near control where it used to be. So naloxone doesn't seem to be as benign as we once thought.
Interesting. Thanks,
And,
Nick.
and John,
By the way,
John, were those, John, real quick for you, those wooden checks, was that with administration of fentanyl by EMS that caused that wooden check?
No, that was illicit fentanyl. We have not
It
seen
was.
fentanyl in a normal dose. I think Jim put in the, just for clarification, we wanted, this person had a rigid jaw that we couldn't basically do airway maneuvers, and that's why we, yeah,
okay.
that's why we paralyzed them.
Oh, then that makes total sense then. Okay,
Yeah.
right, good. Yeah, and I think that what Jim's comment was that it was probably good because if you're increasing vagal tone or whatever
Yeah.
it may be good in cardiac cases and all that thinking.
Yeah. Hey, Peter, there was, actually Nick probably knows the literature, but there was a case report. They had quote unquote human volunteers and they give incremental doses of fentanyl. So there's clearly wooden chest associated with very high dose of fentanyl.
Yeah.
And these are volunteers before IRB came into existence. I can put the reference.
Right. And then and I don't know if it's ethical. We should be telling all our drug addicts out there about testing their fentanyl.
Yeah.
No, but
hey, Paul, we don't,
Go
anecdotally,
ahead.
we have no control over the potency. And obviously it's the potency. We have a huge batch of high potency versus normal potencies versus low. And that actually causes basically the cardiac arrest because they have no idea what they're smoking and or injecting. Most of our overdoses are inhalational overdoses, actually.
Interesting. Okay, got it. And then
And Paul,
yeah, we've seen outright I would say mass casualty incidents in a sense like Jenny and Ben had in Baltimore not too long ago, and others have had. But go ahead, Peter.
yeah, I just want to say, John, your talk at Eagles was my favorite talk, and it really kind of has prompted me to try to change that in my protocols down here, which is adding naloxone to every cardiac arrest protocol. And I mean, after that big study out of Northern California, then your data, I don't see a downside except that it shouldn't be first, right? It shouldn't displace us from doing the basics of BLS and other things. But
well, let me
Paul,
drill down a little bit because you know Peter, you know I'm not a binary guy that something's good or bad, but I do want to drill down and say, John, you saw it mostly in PEA, but did it go with VF cases as well?
Yeah, there was a lot, some cases of VF cases, but honestly, we didn't tease those. There are patients that started out in PEA that went into VF during resuscitation. So it's a mixed bag. So I think we need to be very careful about the assessment, the initial primary rhythm here. Does that make sense?
Yes, that's what kind of what I was getting at too. So, all right. I think, I don't know if everybody's a little saturated on our physiology.
So, hey, before I go, I want to ask Nick, as long as he's here, what adverse effects did you see from naloxone? I'm looking at that blue curve that you actually saw. You know, I'm an EMS guy, so I like colors.
Yeah.
So, what?
You know, that's what we're doing right now. You know, and so you know, if we are gracious enough to get our next grant funded, I'll be able to tell you a lot more on it. But right now, we're the negative effects mainly that we're finding are associated with the massive overshoot that you get from the naloxone. So suddenly ventilation goes, 300 times what it was during control. And you still have the vagal nerve firing like crazy until that sort of normalizes, and you have this mixture of wood and chest. So I think there's still a lot to be fleshed out. The best we can say as of right now is it definitely doesn't go back. It goes into sort of its own unique state. The only physiological thing that we're measuring that's very clear, super robust, is that the animals start sighing, like physiological sighing, like crazy, like 100 times more than they were before.
Yeah. So yeah, but the thing is that also, if it's an overshoot, it doesn't sound like it's a bad thing per se then, so, except for us having to deal with a patient that's wildly, anxious or, whatever it may be at that, from a clinical point of view. But we're also overreading everything a little bit, but point is we need to be thinking this way for the future. And this has been great insights for us. So thank you so much, Nick, and all that.
Yeah, thanks.
All right, let's quickly go around a little bit and Eddie, hey, one thing, hey, Ken, you missed this, but at our, and I don't want to dwell on this too much, but speaking of being a ketamine fan, that Art Kellerman gave a real great talk. I think you should be aware of about. Well, can you do the 30-second elevator pitch, Art, for him about ketamine? Art Kellerman.
Yeah, could you hear me, Paul?
Yes, I can. Yes, sir.
Okay, sorry everybody. I'm actually out in Oregon at a family reunion, so not optimal sound signal, but I'm helping a company that's a plucky outfit that is making a lot of progress with DoD, which is extremely interested in getting FDA to approve ketamine for pre-hospital analgesia. Not that it's not already being used off-label by a lot of you and a lot of folks in the military, but it would greatly facilitate industry producing low fixed dose ketamine for administration in pre-hospital care. So I think this kind of data could be very, very useful.
So it's like an EpiPen approach, kind of, is that you're saying?
Exactly. It would be an auto injector that would, or an emergency injector that would be able, you could pull it out of your pocket and boom, you could immediately give a low fixed dose. So that's pretty much what the military does, but they have to draw it up in a syringe or they take it out into the field or pull it up during resuscitation.
And if the 25 is not enough, then you could always just use another one, right?
Bingo, exactly. And it's typically, I mean, what the Committee on Tactical Combat Casualty Care and about 15 specialist societies have endorsed this, but the FDA is still saying, but it's only an anesthetic. How could you possibly safely use an anesthetic? So we're getting there. We're very close. The Military Health System Research Symposium this week, this is a major topic of conversation. So stay tuned.
All right, the rate limiting factor for EMS, I mean, maybe not for the military, it's going to be cost, right? Because usually those auto injectors are way out of our price range, unfortunately.
I hear you, but fortunately, this particular outfit gets that. And I think they're really working on trying to keep the cost way, way down to be able to facilitate that.
So I just wanted to make sure people like Dr. Shepke and Dr. Jenkins, kind of are aware of what's going on. So that's why I asked you that.
Yes, thank you. Thank you, Paul.
Yeah, that's phenomenal. Ketamine's been a phenomenal painkiller in our system. But I'll tell you, we dilute it in a 50 cc bag of saline, run it over a couple of minutes, because we find that if you don't do that, you get some psychotic, you get a little, you got some psych effects that you don't see when it's diluted. So I don't know if given an IM shot would alleviate, because I think it's not the dose, it's the rapidity of the absorption, I think, is the issue. So do you know of anything if patients are getting any side effects from the IM injection?
There is some of that, but most of the controlled trials, it's a relatively infrequent event. But also for the military, at least, they're really focusing on IM, which would help with that absorption effect.
For obvious reasons, IM is the way to go for their group. But
for the battlefield,
they're finally waking up, not the Army.
Yeah, we're
waking up to this. That's great.
Yeah, there've been 2 C meetings. But we're close, but they're not quite there yet. They're probably going to want 1 or 2 more studies, a dose ranging study, and maybe a small, believe it or not, placebo-controlled trial to prove that ketamine has analgesic properties. And then maybe we'll get a green light.
Almost cruel.
And what we've heard about in the past, of course, is that when ketamine was being used for induction of intubation in the military, that there was less PTSD, et cetera, under those circumstances. So there's a lot of reasons why the military likes this one, which is great.
Yeah,
all right.
I mean, look, yet more proof that Caldwell is wrong. That ketamine is, in fact, the best drug, not droperidol. Droperidol is a second place, but ketamine is where it's at.
Well, unfortunately, Chris is not here for him to hear that. You'll just have to hold that comment till later. All right. That's great. Hey, just before I move on to go around the room with everyone, I'd like to quickly ask John Jude. John, are you available to comment a little bit? And Ken, I think you may have some open mic people talking. Someone's had some people in the background talking. So in any event, John, tell us a little bit about last week. We had a great discussion on dengue and why we're seeing it now more and why we should be worried about it more. And now all of a sudden I'm hearing it's in China and I'm not talking about the dengue. Now we're talking about chikungunya, right? And so that's over in Europe now, right? It's in China. It seems like it's really popping up. And we're even seeing our first case of malaria in your neck of the woods, right? Up in the Pacific Northwest, correct?
Yeah, I think it's all the habitat and multiple exposures to our insect Aedes aegypticus and the other Aedes mosquito. So the dengue fever, especially the ones that we see, most of the time it's mild. So dengue 1, 2, and 3, and 4. If you only get dengue 1, you're not going to have much symptoms besides a cold or a flu. But the repeated exposures of dengue, the second dengue 2 or dengue 3 or dengue 4, I'm just picking it out, a different subvariant will cause an autoreaction and you'll get dengue hemorrhagic fever. And those are a subset here as well. So the bottom line is that this is global warming, as everybody here knows. And I think the issue is that if you look at the dengue map in the 30s, the dengue map in the 30s was really pervasive all the way from the south, deep south to Midwest. And what really stopped the dengue was really not the climate, was mosquito control. Does that make sense as well? And so that for North America, that's so we need to probably pay attention to mosquito control as far as dengue and chikungunya. By the way, I've been following the mosquito control, and pesticides don't really work very well. But if you actually take irradiated mosquitoes and male mosquitoes, that works very well. And so, not that I'm pro radiation, but it seems to be the better part of two evils right now. So, by the way, there is. So you're absolutely right. We need to get a little bit. We've seen dengue in parts of the Northwest as well.
Yeah. All right. So, well, we let's come back. I was hoping Eileen would be on to make some comments, but I think at this point, I just want to make sure people are aware that there are epidemics now really almost edging globally, and some things we haven't seen here yet are coming, and we heard about that a lot last week, especially with dengue. Okay. So let's move around the room real quick. Well, first of all, let me do a quick introduction. Tom Ladaro is now joining us on the road. Are you still on the road right now, Tom, to Rhode Island?
Yes, that's right, Paul. I'm calling in with my 5-month-old daughter, Emerson, here, and thankful to be here.
Yeah, okay, good. Fantastic. Anyways, Tom is just taking over the position in the New Haven, so got the Southern Connecticut area where he's working out of, and has been just really a breath of fresh air there, and going to be wanting him to join us. So we have Southern Connecticut plugged in. He's got New Haven. He works out of Yale, and you're at assistant professor rank, right? And you're over the section of EMS for them. Anything else we should add to that, Tom?
That's right. So I'm an associate professor in the Department of Emergency Medicine, serving as a section chief at Yale School of Medicine, and then for the Yale New Haven Health System from Westerly, Rhode Island to Greenwich, Connecticut, I serve as the chief of emergency medical services for the health system, basically. So, and I'm kind of a disaster doc as well. And we've got a great team out here at a fellowship. So if anybody's got people looking, check us out. Thank you.
Right. And then you also are the medical director for the Office of Emergency Preparedness for Yale's health system as well, correct? Is that what you're saying?
Yes, that's correct.
Okay, that's right. You're an associate professor and you got a public health degree. Where were you before this? Tell us about that.
So last 8 or 9 years, I was out at IU Health. Previously served as a medical director for Indianapolis Fire Department, deputy medical director for Indianapolis EMS, and then had about 6 or 7 years of service at our state's largest interfacility transport agency, IU Health Lifeline, 5 helicopters and about 38 ground ambulances and 600 team members. So
Yeah.
that was a fun time out there, and a little bit different out in the Northeast, I'll tell you that, as you know.
Well, you also have oversight of Emerson as well, right? So
yes, that's right. That's right.
But you want to explain who she is?
Yeah, so Emerson's my my first child, baby daughter, born March 3rd, and Brooks, my wife, and I are just over the moon, and
Yeah.
it's definitely the most exciting thing that's happened to me in my entire life. So very thankful.
That's right. Well, listen, welcome to the team here, and hope you have you been able to listen into this pretty much during your travels there.
Oh yeah, this has been fantastic, and I'm hoping to be a frequent listener and contribute where I can. So this is wonderful, and thank you all for your insights and knowledge.
Well, the single most important thing is block out the calendar next June 1st through 5th, okay? Because you'll see that's going to be the gathering is the greatest thing. It's really so much fun when we're all together. All right. Well, in the meantime, we'll be searching out hopefully some Italian restaurants next week, okay? So, all righty.
Looking forward to it.
Looking forward to seeing you. All right. So let's go around the room. Joelle, are you still here with us? I thought Janelle for a while, but maybe we lost her. So, because we're going to lose a few people here. We hadn't heard from her for a while. Well, then let me go ahead and jump over to Don Jenkins and give a reflection on your sense from the meetings yesterday with Dr. Shepke. And anything else you want to report on?
Yeah, the group is really got a head start, a running start on this, and I think there was one specific piece of data that really seemed important to the legislators, which was this NHTSA traffic fatality data with the percentage alive at scene. It gives you sort of a number that you shoot for. And it seems that there's even greater opportunity in Florida than in Texas, where it was, Ken, if I recall correctly, it was approaching 50% of those traffic fatalities were still alive at the scene when EMS got there, which gives you a great opportunity to save those who died of hemorrhage on the in-between. In rural parts of Texas, that number is down in the low 20s as a percentage, and we think that has more to do with timing of discovery or EMS arrival and that finite period of life after those fatal crashes.
Makes sense.
The one thing I did want to throw in on what Ken and Art were talking about with ketamine is that it also has been demonstrated in amputees, U.S. warfighters, amputees to decrease limb neurogenic pain and phantom limb pain development.
Cool.
Yeah. So.
Well, anyways, we want to thank you once again also for joining us in Salt Lake in a few weeks here. It's coming up, right? So thanks again for doing that, and always contributing your time and in your efforts to help us all advance this stuff and just learn more about where we're going next. So I think in a week or so, maybe I'll come in. Maybe you and I can jointly talk about the sex-related and hormone-related issues as well, and that would be kind of a fun thing to get the group thinking about. Okay.
Yeah, I think it'd be great, Paul. You have a fantastic background with that research you have done.
Yeah.
And for the rest of the group, we're going to have Paul, if we can bring him in as a visiting professor. Otherwise, we'll do it virtually. Going to take the next step forward with plasma for TBI here in San Antonio. Potentially, we'll do that in the hospital. Help prove some of that benefit, and maybe get that in the pre-hospital setting as well.
Okay, good. Fantastic. Well, obviously it was from taking the lead from Ken and Peter, et cetera. And, but the shaping the talk was great also with John's help. And, but I think taking us to the next level, the discoveries we have of like the green plasma and all that, it's just going to be, this is really exciting. I think we're just getting started. David Miramonte, is there anything you want to add while I got you sitting there?
Just give blood products, plasma, whatever you got in the bucket, and hurry up and get that sprayed freeze-dried plasma on the truck and at a decent price, as we talked about before.
Yes. Yeah. And that's exactly it. So anyway, save the calyx, right?
Save the calyx.
We're gonna
Salt
get
waters for making pasta. That's it.
yeah. So I think I'll get a T-shirt next, right? So yeah, did you see what I was wearing today, David? I got the welcome back, my friends shirt on. Right? So I'm going to get one that says "Save the Glycocalyx," right? It's like instead of "Save the whales," whatever, right? Okay, good. Angus, anything out of Florida we should know about, or Tampa Bay area? Sorry to catch you off guard, or maybe you are offline. I don't know. Maybe you are. All right. And I will be in the Tampa area not too long. Ken, are you going to the or you or Peter, are you going to the what do you call it? Meeting, the stroke?
Yeah, I'm gonna be there.
Yeah. Okay. Good. I'll see you there then. Good. Are you coming Thursday evening?
Yep. Yeah, I'll be there
Oh,
Thursday.
let's get together
Yeah.
that night.
You know,
Yeah.
while you got me on, I was gonna say the mosquito stuff because we have a lot of issues with that in Florida. And it's kind of interesting. What we get is that these are travelers that catch these things elsewhere, come back to Florida, and then they infect our mosquitoes. And that's how they get looked up. But I just saw a study. We just had a study from my colleagues in the Department of Health. It doesn't sustain itself. Like, why does it die out? Because as you know, as was already pointed out, they should keep going. We got to have that for it. And it turns out that air condition might be the issue. You know, the people aren't exposed to mosquitoes like they were in the 20s and 30s, probably because everybody's indoors air conditioned with the windows closed.
Yeah. Well, the other thing you should know, and that's why one of the reasons I wanted to establish a relationship with you and Jennifer Schuffert here in the commissioner here of health in Florida, is because that's been a focus for her as well, especially along the border, and they're seeing the dengue and all those other things as well. So she could be a good person to communicate with because they're having similar problems.
Yeah, we've had a bunch of outbreaks. We had to deal with mosquito control, just like John was talking about. But it always seems to die out, though, which we're lucky.
While we're on it, Don, you want to tell them real quickly about what you've observed down there along the coast, the coast of the western coast of along the Rio Grande.
Yeah, down in the Colonias, all these little border towns that have a handle pump well at the end of the block and open sewers. Dengue is endemic, and one of the concerns I've had, is the potential effect on the military blood supply, because of what the nature of that comes from the 600 young people that show up every week to Lackland Air Force Base to join the Air Force, and they are there long enough to donate blood twice. And of course, they all volunteer to do that. And the concern I've always had is that they would contract dengue while doing all of their physical training things, and donate blood that was carrying dengue. Because the symptoms typically for the first exposure are mild. It causes you to be tired and achy and cranky, and that's every airman going through basic training every day. And so you wouldn't know by screening potentially that would be an issue. I actually worked with a guy to develop NAT testing to do that specifically for the Air Force. So that we could make sure that blood supply that ends up overseas and being transfused to combat casualties wasn't tainted with dengue.
Okay, thanks. All right, yeah, I just wanted to make sure he was aware of that. It's been interesting stuff I've learned from you all the last little while. Let me quickly move on though, because I want to get through the crowd. Let's go first with Mark Cohen because we haven't seen you for a couple of weeks. And what's the latest in Los Angeles?
Oh, hey, yeah, it's been a few weeks since I've been able to make any kind of meaningful report here. The report today, not so much EMS, nothing very exciting there. I think I mentioned last time our funding for blood has kind of been put on hold. But we're already moving into our suppression season. Speaking of global warming, we've got a major wildfire in the north part of the county, which also coincides with Department of Water and Power accidentally cutting off water to about 10,000 residents, which includes fire hydrants. So we've got water tenders and things like that. So everything on this end is moving to a suppression thing this week. So not so much EMS. But it looks like it's going to be a very long wildfire season here.
Yeah. So I know the Gifford fire is really big, but you got the Canyon fire almost coming towards Holmes, right? Is that right?
That's the one. So it seems to be not so much in threatening the homes in Ventura County where it started, but there's a lot of concern right now. It's going to jump over and hit some of the sort of densely populated suburbs up near Santa Clarita, Castaic, and things like that. So we will see. Yep.
Yeah. All right, good. Well, it's great to see you. I don't know if I'm seeing you, but at least to hear from you. So, which is great. Thanks for being on. Let's jump up Route 5 though and go hit Vancouver. What's happened up there? Anything, David, to report?
Nothing to report at the moment, Paul. Things are.
You guys getting smoke there from coming the other direction? It usually goes easterly, right?
Yeah, fortunately for the moment, we don't have a lot of smoke in the Vancouver area. There's some fires in the very far northeastern reaches of the province, but nothing close to the lower mainland.
Yeah. Okay, good. And meanwhile, Libby, anything happening out in your realm along these lines, or in the public health realm anyways?
It's the second anniversary of the Maui wildfires.
Right.
So that's a big deal for us here. With regard to dengue, we see cases in Hawaii, but thankfully it's still limited to travelers who get infected abroad and then come back and bring it. It's all across the South Pacific. So people going to Samoa and stuff like that bring it back. So we're trying really hard that it not become endemic here.
Yeah. Well, it is interesting. I always think about how when we started having aircraft going from different places, like that's how West Nile got out of West Nile area into New York City, coming over on a 747 out of Tel Aviv, that kind of thing. And so now we're just enhancing that for every kind of virus out there. Hey, speaking of which, there's recent reports showing that there were more suicides that were happening, in your territory there. And is that a significant impact or just an interesting signal that you're seeing, or you think it's a very major sociological events happening?
They're looking at a lot of behavioral health stuff tied to the Maui wildfires. It was so devastating, and people lost their livelihood and they lost their homes, and 102 people died in the Maui wildfire. So I think some of it is the after effects. And what's really interesting is that they're seeing it, profound depression in kids, like elementary school age kids and high schoolers. And that's just, that's devastating when you have a little kid that is that profoundly depressed.
I'll tell you, one of the things that sort of freaks me out a little bit about it is this thing just came down so fast. So people just, boom, trying to get out of there. And then the issue, like, well, I'll just get into the water, right? And then what happened, unfortunately, because of all the damage, there was the gasoline, spills that are, and the oil that were getting out into the thing. And so they went on fire out there and drowned as well as being burned. But that was like a bizarre, something I hadn't encountered before. There were a lot of people out there in that circumstance. Isn't that correct?
Yeah. Yeah, they tried to jump into the harbor, into the ocean to escape the fire. And the fuel tanks, I think, at the end of the pier down on the wharf exploded. And so it sent fuel, a blanket of fuel across the surface of the water.
Yeah. That was just like awful. That's all I could say. It's one of the more things that sticks out in my brain. So, all right. Well, thanks a lot. And then you're doing well, I hope.
Yep. Everything else is going well here. Thanks.
Good. I'm glad to hear that. Okay. And then let's see. Okay, let's then jump. John, let's just go down. We'll go down I-5 anyways. And John, anything else report out of Portland? Anything new there?
Nothing new from Portland.
Okay, good. All right, let's go on down. I'm just going to go down the list. David, anything else to add out of San Antonio right now?
I'm still deployed up in Kerrville.
Yeah, that's what I was going to ask you if you're still down there. Yes. Okay.
Yeah, so Dr. Harper, myself, and CJ have been taking turns in the clinic. We're doing a force protection clinic for the firefighters. task forces, the footprint is shrinking rapidly this week. So
Yeah.
we don't know
Good.
how to. We have one little girl that's not been found from Camp Mystic that they're still looking for, and we have one gentleman that's
Yeah.
not been found.
As you know, most of us are involved in these things all the time. Like I've always reported, is that the majority of my job has always been to take care of the rescuers, right? And so that's exactly what's happening here. But the footprint is going down. Then that's great. Then I'm glad to hear.
Yep.
Oh, thank you. That's good to hear. Okay. Then let's go. Hey, Nick, let's go talk to you. What happened to Santa Claus?
It was getting too unruly. It just had to go.
Was it under demand of the nurses or
Yeah, pretty much. Pretty much.
That's great. Well, it's great to see it. And by the way, I want you to know Stein Bronski, okay, his family comes from Salt Lake City, and they said if you can't get someone to help you out, he will supply support. So I want to get the two of you together, okay? So
Okay.
you know, because we got to make sure you can get mobilized around. You're giving your time and effort, and
Well, I have, so kids aren't allowed to come, but
Ah.
one of my architect buddies is going to come because he wants to see the high desert architecture of Salt Lake. So we're going to come a couple of days early so he
Ah.
can see some of the interesting architecture around.
Okay, but I'm still going to try to get you and Stein and also Scott Youngquist plugged in. Scott's been very helpful in trying to set things up. Like, for example, just in general for ASAP, I have to say that, for example, they needed a bed for an ultrasound demonstration they're going to do in the exhibitor area. He got it from his training area. So it's just our group has been very cooperative, and they're very happy. ASAP, by the way, I should mention, has a new executive director appointed as of last night. He's still going to be on the job where he is right now up until I think November, but he's going to pop in and out, and he's actually wants to pop in and say hi to us. He's heard a lot of good things about the Eagles group, so we'll get to meet him with Sandy, and so I just wanted to give you a heads up about that. If you have someone coming on who it is, they've found. I think he's been a person who's been an executive director for, I can't remember what the background is, for the Professional Society for Pathologists. But I'm going to look into it a little bit more. The announcement came in last night, and you may have seen it. Okay. Let me see.
Did you want the updates?
Oh God, yes, that's why. Yeah. All right. No, not from you. You're been in.
So we're back to storm warnings again during
okay.
the height of summer. So we had the newest one is Storm Florist. These things are all alphabetical.
Yeah.
And hit the northeast coast, Donegal, Sligo, put about 15,000 houses out of electricity for 4 days. But
Now, has it all just been high winds, or has it also been the flooding that you saw a couple of years ago?
High winds, flooding, and extreme rain. So the floods are coming from the surge onto the beaches and places, but the rivers are not draining in because there's such drive from the surge force coming back that the rivers are blacking up.
So for us, it begs the question for me, and I know that like several years, what was it, 2 or 3 years ago, during the whole summer, it eroded the roadway, so that made it difficult for ambulances. But is it actually impossible because the roadways got debris on it, or they're just obstructed?
No, so in those areas there's a lot of highland as well. So the highland areas, there are floods on the roads, but they have 4x4 vehicles that they will go out to.
Okay.
And then wait to do the transport at a later time when the weather comes down a little bit.
Okay.
But that was an interesting time period because that county up in Donegal ended up in our All-Ireland final, which is the Super Bowl. And the big focus here was Matt Broderick and Sarah Jessica Parker were up there in their holiday home, and they were all cheering for Donegal, but they got caught in the middle of this storm. So it was all about, how will the celebrity survive?
Yeah, right.
But it's been 2 weeks of major events. We have the 150th Dublin Horse Show. There's something like 300,000 or 400,000 people attending that.
Yeah.
We have the Fla Festival is on in the town I work in, Wexford, which normally is a 25,000 population town. During the week, there'll be 780,000 people attending the festivals, but a peak of one day of 200,000, which is enormous. And during the week, we had a significant security issue because Ed Sheeran decided to do an unannounced gig in a pub and there were 40,000 people trying to queue up outside and get in. Every road around the place was blocked. So interesting small things which can cause unusual issues with your access and roads and trying to move
Yes.
population around.
And it's difficult in the first place anyways,
Yeah.
and especially out there with the cow paths, right, in some areas. All right, well, yeah, it's all right. We'll have a talk about that. We'll have you talk about that sometime. It'd be fun. All right, so I'm trying to think of anybody I missed here. Roger, are you still here? Yeah, probably real quickly because it's already 12 noon your time.
Sure. Real quick, I'd let the group know about our adding portable ventilators to our ROS bundle of care. I'm starting to look at some data, and I'm not sure if it's going to reach statistical significance because at the sustained ROS where we get vents on is about 71 or so people out of about 500 total arrests. But one thing is that the group that were missed opportunities, either because the vents were out of service, whatever, within the same post-implementation group, there are no survivors in the group that didn't get the vent. And there's, about 10% CPC 1 and 2 survivals in the group that did. So I think it might be a trend towards, promising results without necessarily reaching statistical significance, but I'll know about that. And the other thing is we're in the midst of a little a protocol discussion, and we're trying to get the low-hanging fruit from June's meeting into potential protocol stuff, including wall motion in empty hearts in traumatic arrest in PEA. So stay tuned. So we're really trying to apply some of the stuff we're seeing. And then one last thing is the group. I'm getting a bunch of activity, and Pete, Dr. Antebi may have seen this activity group, an activity level by the Society for Vascular and Interventional Neurologists, who are trying to apply what they learned in the visit on July 14th and get back to the legislature with maybe even some legislation that codifies what they were visiting for. So, Pete, if you have anything to add to that's all I got. Thanks.
Yeah, I just say that they're really smart group of people who are gonna get it done. So that partnership that Paul has been helping along with bringing Regestion for years to Eagles is really coming to fruition. It's finally bearing fruit. So it's a group that we should definitely keep close to.
Yeah. I won't talk about it today. I took the ASLS course as a paramedic. And so I have some interesting things to report. I'm going to be looking at what David Wittberg does in an hour and a half, which sounds like it might be good. Had you get to see that, Roger, by any chance? David's course that he puts on? Okay, that's okay that I lost him. Mike, anything out of Toronto we should know about before I got to wrap this up? Mike Feldman, anything out of Toronto to report? Okay, I think everybody's finished for the day. I don't blame them. It's been a long day. So, which again, Mike, is there anything else to report out of Toronto? You're cool. Thank you once again. Actually, I had you on speed dial with somebody who was a friend of mine who was our commissioner of health for the state of Texas, was traveling through Ontario. And I was going to basically, I told her, call me if something came up, because I know someone who can work miracles up there, right? In the Canadian Wonderland. So, okay. So good. Thanks again for your help, always. All right, and Tom, we'll have you give a report maybe when there's a good time for you in a week or so, and then tell us a little bit about your system and then what the issues you're dealing with, and maybe we can even help you out. One of the things that this group does is that none of us think that we're doing something better than the other, but if we can help you, we will, because we're not the expert in your area. You are, and you have to be, right? So that's the whole attitude of the group, and it's been fantastic to work with. And then Bill Baumer, I don't know if you want to get together with Jim Augustine and then talk a little bit about the cancer risk. I don't, and some of the things that you just, I think, emailed to me about. But if you guys want to continue that series, it was very well received last week, by the way. Everybody was really liked your presentation on the cardiovascular risk. So thank you so much. And that will probably be available. I'll have to check with Julian, but that'll probably be available on our webinar listing from our website, so people can go back and see that if they like. So, all right. Anything else for anybody? I better get out of here now. So I'm taking up a space here. If not, then welcome back, my friends, to the show that never ends. Okay. And see you next Friday, which is hopefully I might be reporting from New York, but hopefully with right along there with Glenn, but probably going to be hopefully back in Texas by then. I'll be doing lots of trips here. Okay. Ken, anything, well, you
All
want to
right.
see, Ken, anything you want to add about Palm Beach or anything like that, or that?
Oh, no. I was just gonna wave by as you were signing off. That's all.
Good. Thank you for your time. When was it? Not last night, but the night before. That was great catching up on all those things. So the list of 2 things that expanded to 5, right? But you heard from Don, that he thinks this is going to be good stuff, and I know you're going to be you'll be the tip of the sword, get that stuff done. Okay, so
I'm gonna try. Yeah.
Okay, good. Yeah, I'll even give you a personal presentation sometime. Okay, well, thanks a lot. Okay, thank you all. See you later. Take care. Bye-bye.
Bye, everyone. See you.
Thanks, Paul.
All right, thank you.